Hi, everyone. Welcome to this co-sponsored event from the Department of Medicine Inclusion Council and the Internal Medicine Residency. Doctors Ju and Biggers, who are the co-chairs of the DOM Inclusion Council, will be joining us a little bit later today due to clinical commitments this morning. My name is Gina Kwok. I'm one of the Internal Medicine Chief Residents. We're so excited today to have Dr. Andrew Trotter and Dr. Sarah Messmer present on the topic of providing LGBTQIA+ inclusive care in a case-based discussion. Before I introduce our speakers, we'd like to start with a welcome from our department chair, Dr. Patricia Finn.
Hi, everybody. I want to give you a really warm welcome. My name is Patricia Finn, and I'm the chair of medicine. And I am really proud to just sing the praises of everybody involved in not only in today's lecture, but I think our commitment of inclusion and exceptional care for all. I want to particularly call out Alana Biggers and Minju, who Gina has already mentioned, but really trying to think about how do we promote in our day-to-day lives best care for our patients and inclusion. And I'm particularly so delighted with our two speakers who you'll hear more about and more from, and from whom I learned so much from each time I listen to them. So warm welcome to everybody. Remember, these are online, these are recorded. So if you can't make it, send it out, spread it to a friend, and welcome everybody.
Thank you, Dr. Finn. So before I introduce our speakers, we would like to make everyone aware that today's session will be recorded and publicly available. We encourage questions and discussion through the chat or through unmuting yourself. If you would like to remain anonymous to the group, please feel free to send me a personal chat and Dr. Ju and Dr. Biggers once they do log on, and we can help moderate the discussion. So Dr. Andrew Trotter is an assistant professor of clinical medicine in the Division of Infectious Disease, Immunology, and International Medicine in the Department of Medicine at UIC and UI Health. Dr. Trotter's research and professional interests include biomedical interventions for HIV prevention, HIV treatment, prevention and treatment of sexually transmitted infections, LGBTQ+ health and gender-affirming care, hepatitis C, and the care of marginalized populations, both in Chicago and in international settings. He has significant experience in international health, including in Nepal, Namibia, and India. Dr. Sarah Messmer is an assistant professor of clinical medicine and pediatrics at UIC. She practices in both the inpatient and outpatient settings in both pediatric and internal medicine. She is passionate about providing LGBTQIA+ affirming and inclusive care. She also has a strong interest in opioid use disorder and addressing stigma and bias towards people living with addiction. She currently leads a project to integrate education on opioid use disorder into the medical school curriculum here at UIC. She works twice a week on the West Side in Austin, providing primary care and Suboxone treatment at the School of Public Health's Community Outreach Intervention Project, which is focused on harm reduction services, including syringe exchange. On top of all her clinical and research duties, she also finds time to work closely with medical students and teach the next generation as a physician house advisor in the College of Medicine. Thank you both.
Thank you, Gina. So let me share my screen. Okay, can people see the screen okay?
Perfect.
Okay, great, thank you. So welcome everybody. We're really excited to have this session. And we really wanted to have this session to be more case-based and discussion-based and have more time to discuss cases as a larger group, but also in small groups. So we're pretty excited to have this time to do that. So this session really complements some of our previous sessions in the Department of Medicine Inclusion Council discussing LGBTQ health and inclusive care. And I would invite you, if you want to gain more background or weren't aware of those videos, they are posted on the website, so you can watch them at any time. And we really wanted to have this session be a conversation and discussion as opposed to just lecture and information, but there'll be kind of a mix of that, I think, to really allow us to think about ways to apply address and manage or approach certain clinical situations or real world settings where these situations may come up. And I really feel that we feel that these really apply across all disciplines and all settings of care. And I think that they can be adapted to fit probably you in whatever, discipline, field of study or role that you have. We're really excited to go through these cases and have some discussions. I wanted to just go over a few things about how this will work and kind of our ideas as we enter into like this session and discussions. So again, this is case and discussion based. The more you put into it, the more you'll get out of it. So we really want to encourage discussion, both in the small groups that we'll have in breakout sessions, as well as in the larger group. I do want to say that this is a safe space for us to have these discussions. Please remember to be respectful and use each other's pronouns. I would encourage you to put them in your name. And I would, on a side note, encourage you to do that all the time because I see that more and more people are doing it, but I think that it's important acknowledgement and I think creates an environment for us to all do that. So I think that's really, it's really great to start seeing that. Remember that, in discussions, there may be situations that you're not familiar with. If you, say something or feel like you made a mistake, it's okay to just acknowledge that and also participate as much as you feel comfortable. We understand that you may be, driving somewhere or something where you may not be able to fully participate, and that's okay. But we would encourage you to participate as much as you feel comfortable doing that. And I would also just say that I think I would encourage everybody to ground your statements and discussions around your own personal experience. And remember that nobody's experience is universal. And so that we can really share and learn from each other and our experiences. And I would encourage, especially when we get into the groups, or if you want to be taught, bring up a point or discussion, please use the camera as much as possible. We all know how interesting these virtual sessions are as far as, participation and things, but I would really encourage you to use the camera as much as possible to really help with engagement in our discussions and for us to get to know each other and I think make the discussion as engaging as possible. Just a brief information about how this will work. So I have a brief introductory slide, just kind of about some terms that will probably be used in some of the cases, will be used in some of the cases and probably relevant to our discussions. And then we're going to review each of the cases. And as a large group, I'll just read, one of us, Dr. Mesmer or I will read through the case and the questions in a large group. And then you'll be split into smaller discussion groups where we would like you to talk about the questions for the case and kind of discuss what you feel as far as responses for the case, for those questions or any topics that the cases bring up. Those sessions will be around 5 to 7 minutes, depending on the case. And then we want you to, as a group, pick someone to share some of your discussion or responses to the questions to the larger group. So after the small group, we'll come back in a larger group, and then we'll go through each of the groups and ask for some feedback and responses to the questions. We realize that as we go through the groups that some of the responses or ideas may be shared, things that everybody has discussed about, and that's fine. I would just suggest that if that's the case, you can just say that that your group discussed this and we agree about the importance of X issue or this approach. If you have a different take on it, please share that. But I think that'll help us get through the kind of larger discussion in a more efficient manner. And also, even the questions may bring up discussions, or you may have your group may have questions about how to deal with different issues related to the case that's not specifically addressed in the questions, and that's fine to bring those up as well as as we go through each of the groups' discussions and viewpoints that they had in the small group. So I think that's about the session. The last slide that I wanted to go through is this diagram, which I'm sure many of you have seen different iterations of it. There's an elephant, there's a gingerbread person, there's a unicorn, there's like lots of different diagrams that are used to try to capture some of these aspects of gender identity expression and emotional and romantic as well as sexual attraction to individuals. And I wanted to just we wanted to talk about this just briefly because I think this just provides a little bit of a basis and trying to get everybody on the a level playing field, because we understand that some of you in the audience may not have a lot of experience with this yet, and this may be an introductory session for you. So just as a reminder, really gender identity and then sexual orientation, gender expression are really separate aspects grounded in different concepts. Gender identity is really about the individual and how you see yourself and their gender identity. And it can be binary in that it's mostly male or female based on social norms, or it may be mixed, or maybe neither. And it can have various combinations of both. And people may identify as transgender, for instance, gender non-binary, or gender fluid, or something else. And so there's really kind of a spectrum of different aspects that individuals have in terms of gender identity. Gender expression really captures how an individual expresses themselves to an outside world. So you may describe this in kind of the clothes you wear, your body type, different physical attributes. And this is, in a social or a society perspective, traditionally discussed, thought of as masculine or feminine, other, in between, combinations of both. And so this is really about the outward expression. Sex assigned at birth is just the sex that's assigned at birth for the individual. And it could be male or female, or other, or intersex, for instance. Again, is independent of an individual's current gender identity expression or sexual orientation. And then sexual orientation really has to do with physical and emotional attraction to others, either binary men, cisgender men or women, other genders, transgender individuals, non-binary individuals, or people of any gender, really. I think what's nice about this diagram is it separates physical and emotional attraction, because some people either identify as asexual, or not having sexual attraction to others, or aromantic. And so these are different terms describing gender or sexual orientation. So I think this kind of diagram kind of splits out some of these aspects in a very overarching perspective. And I think the thing that I would just highlight is that these are all independent attributes or identities of an individual. They're not linked to each other necessarily. They're grounded in the individual, and they can be fluid over time. And so those, I think, are important to keep in mind, both when we're approaching patient situations, even our coworkers and our work environments, and just these ideas. So that was just the basic overview. Sarah, did you have anything you wanted to add?
No, I think you summarized it very well. And I think particularly in healthcare settings, recognizing that gender expression can be completely separate from gender identity, especially if a patient may not feel comfortable expressing their gender identity. And that's why it's really important to create a space where patients can share that information. I also wanted to let you know, Dr. Trotter, if you'd like, I don't know if you want to answer this question in the chat about how much LGBTQIA education training all staff gets, like frontline administrators, or admin, MAs, lab, et cetera. I know we have had the safe zone trainings, and there are some modules in the onboarding process. Do you know of anything further beyond?
Well, I know that because of the HEI, the Human Rights Campaign Health Equity Index, since we have been evaluated and been rated for that, there is ways through the intranet to do modules through them as well that cover a wide range of topics related to LGBTQ health for all of our staff. So it's anybody in the health system that's open to. And I believe there's also a way to do trainings there's instructions on the internet through the LGBTQ national education center. And both of those, I think some of them also have continuing education opportunities. Okay, great. So I think we can move to the first case. Okay, Sarah, did you want to go through this case?
Yes, and so just to remind folks what we're going to do, I'm just going to read through the case. We have a couple of discussion questions, and then I'm going to create some breakout rooms. And I'm purposely putting about 10 or 11 people per room, recognizing there may be a couple folks in each room who are not able to discuss for, maybe you're in clinic or driving or something. But I'm hoping there'll be enough people in each room to have somewhat of a discussion. And then we come back, we're going to ask folks to share just some of their thoughts about the case. So please be ready to have somebody from your group share what you talked about. So for this first case, you are in your general medicine clinic. So for the residents in GMC, you're seeing a new patient listed as a 30-year-old man in Epic. He is cisgender. He uses he, him pronouns. So cisgender, I can't remember if you specifically said this, but cis meaning that gender identity is in alignment or matches sex assigned at birth. During your social history, you learn that he currently has 2 partners in a committed relationship. One is non-binary, was assigned male at birth. The other is a cisgender man. They all live together and they've been together for 3 years. So the first question we want you to think about is, what would you want to know about, you're getting to the sexual history portion and sort of recommendations part of your evaluation for your new patient. What do you want to know about this patient's sexual history? What questions would you ask? And then what recommendations do you provide regarding sexually transmitted infection testing and prevention? And is this different from your approach with your heterosexual monogamous patients? And then lastly, how would you discuss condom use with your patient? Any questions about these questions or the plan? Okay, I'm going to open up the breakout rooms. And we're going to give you about 5 minutes to discuss. You'll get a 30-second warning when the rooms are about to close, and then you'll be automatically brought back. If you can keep an eye on what room number you are, just so that, because we might call on some specific rooms if people are not volunteering, and then just pick somebody to share at least a couple of thoughts about your approach to this. Anything else you'd add, Dr. Trotter?
Nope, I think that's all.
All right, we'll open up the rooms now. Okay, everyone should be in a room.
Sarah, do you know that if I go into a room, will this screen still be there? Because I want it to be available to everybody.
So the screens don't show up in the breakout rooms. I can broadcast a message to everyone with the questions.
Okay.
I can do that with my broken arm.
Oh, I can, can I do that?
I think I might be the only one who can. Maybe
Okay.
I can copy and paste. I'll work on that.
Okay, well, we could copy and paste it into a message to everybody, maybe.
Yeah, well, that's what I was gonna try to do. Let me do that really quickly. I'll broadcast the questions. Did you see that pop up? Oh, I didn't start my timer. I'll start that now.
I can see it.
Okay. Do the last one. The only hard part about the broadcasting is that it's like it doesn't stay the whole time. It just kind of appears.
You should be able to pop in and out of the rooms if you want to just see how they're going as the presenters.
Yeah, maybe I'll do that. Well, there's a couple people that I think have joined, and then I add them into different rooms. Room 8 had some people leave. Yeah, part of the reason I stay in the main room is that if like somebody new joins, I can put them in. Only about 2 minutes, and then we'll bring people back. Let me know if anyone on here is trying to join a room and can't for some reason. If you're in a situation where you just aren't like, able to fully participate but want to listen in, that's fine too, and can let you be. But if you're trying to join and having trouble, let me know. All right, I'm gonna give people the 30-second warning. As folks are coming back in, if you've been elected the person to share for your group, if you'd be willing to pop your camera on, that would be great. If you can't turn your camera on, and then I'll just have you jump in when it's your turn. But a few more seconds, just waiting for everybody to come back. Did the rooms work okay for everybody? Have some good discussion? I like that popsicle background that you have over there. It's beautiful. Thank you. Yeah. Okay. I think everyone should be coming back. Andrew, do you want to put the slide back up with the case questions really quick so people can see them? Just, does everyone have the questions still? Okay.
Yeah, Sarah, is there a way besides messaging like you did, is there any way that besides doing a screenshot that we can keep them readily available? I don't know what the best way would be.
I think we can put them back in the chat before we go out. That might be the best way. And then, or if folks want to just take a quick picture of the questions, that's another option. But I think we'll try putting them in the chat for the next one. I hate how that disappears when you go into breakout rooms, but all right. I hope folks had a good discussion. Does any brave group want to share some of your thoughts about these questions to start us off?
I'll start off for question number 1. One thing Dr. Pierre shared with us is like recommending like starting with a broader conversation about relationship satisfaction, both like emotional and sexual satisfaction in terms of taking the sexual history. So I thought that was, I think, insightful.
Yeah, that's great. Did your group have other thoughts on the second and third questions? Or actually, why don't we just stick with the first question?
Okay.
Did other groups think about the first question? Any additional pieces that you'd add?
We'd want to ask about specifically, are they fluid bonded? What do they consider to be, like, does it mean who do you have sex with? And is that a relationship or is that a casual partner? And do you use condoms? And when do you do that? And yes, Robert was in my group, and we also talked about getting everybody on PrEP regardless of whatever else is going on, because they're there.
So I think your first point is really great. You mentioned you don't know if maybe they are a couple, but maybe they're not sexually active with each other. You don't really know, but they seem like they're in a committed relationship. That doesn't necessarily mean that it's a sexual relationship. So that's a really great point. And then you brought up PrEP. How do you decide who to talk to about PrEP? What did your group discuss? Oh, and someone wanted you to elaborate more on the fluid bonded.
Yeah, thank you. You know what? That might be, there's probably a newer term for it, but essentially it's a concept that you have a person or a group of persons with whom you exchange fluids, all body fluids, freely and without using barrier protection, but with the agreement that outside of your person or persons in the group that you would always use a condom for every sex act, everything that would involve body fluid, including oral sex. And sometimes it doesn't mean oral sex for people. And that's, I mean, I never use fluid bonded with patients. I just say, you know, like, who do you have sex with? What's your agreement? Do you use condoms with them? And so forth like that. And our PrEP discussion was really brief, like just that multiple sexual partners, great person to consider PrEP. We should have that discussion.
Right. What did other groups think?
I have a question. We were room 8. We had a little bit of a discussion, but that someone was saying, okay, usually ask sexual history, you know, do you have, are you sexually active with men, women, or both? And we were wondering if there's a more inclusive way of phrasing that, which would allow more room for, you know, non-binary, gender fluid phrasing.
I love that you brought that up. That was one of the big things we wanted to also mention for this. I was taught that phrase in medical school, like men, women, or both, as like a, oh, look, we're including, you know, options here, but you're completely right. It's very binary and it excludes folks who don't identify within the binary. So I think you can always ask, tell me about your partners, or tell me about like, who do you have sex with, or just trying to use more kind of general terms as a good approach. You know, I think there's a lot of different ways that people approach this conversation. So I'm excited to hear people share some. I'll share a little bit more about the way I ask questions. I'm sure Dr. Trotter will too, after we hear from more groups. But I love that you brought that up, because that was something I was going to bring up if no one did. So that's great. Did other groups have thoughts about that first question? Other things that you would be interested? Also, if folks want to put things in the chat, feel free as well. We're keeping an eye on it too. Any other thoughts from the other groups?
Our group talked a little bit about just using open-ended questions and trying to create an environment of a safe space where we're not making assumptions.
Yeah, assumptions are going to be are the downfall for everyone. I think I can actually share, I just recently became a patient. I broke my arm a few days ago, which stinks, but you know, it is what it is. And when getting my registration information, they immediately, the person registering me said, oh, is that yours? Is that your insurance or your husband? So I was like, well, it's my wife's, but so, you know, it happens in those little moments all the time where assumptions are made. And that's when you find yourself, you know, in a more awkward situation where you're like, I wish I hadn't assumed that. So as much as you can try to take all those assumptions out is really important. Other thoughts? Let me see here. Identity partners is not as useful as, yeah, I like this comment about the identity of the partners is not as useful as what body parts you have sex with, you know, because that helps us determine where someone might need to be tested. Exactly. And then I see a question. I would like to hear more about how you asked the question about sexual partners to be more inclusive. I feel like if I say, tell me about your sexual partners, some patients will be confused and jump into their life stories. That's true. And then what parts used for sex, which is really the relevant part of the STD testing and screening. Yeah, I think that those are all really great points and questions. I can share my approach, I think, and folks feel free to add more about this first question. I often just talk with my patient about, I sort of say, I offer STI testing at basically every visit with all my patients. And I then talk about the different places we can test and sort of why we test different places, and I allow patients to have a discussion together about where they want to be tested. And often I start phrasing it more like that as opposed to specifics of like, what type of sex are you having exactly, so that patients can just be like, oh, well, why don't we just, swab here, or swab this area? And I think that's the approach I've kind of gotten to over time, because I feel like it allows patients to share as much as they feel comfortable, but still have the opportunity to ask for whatever testing they need to be safe. So Dr. Trotter, do you have other thoughts about how you like to ask those questions?
Yeah, no, I think I've moved over time more to that approach too. And I think it also gives patients a sense of understanding, education, and empowerment about the fact that we don't, because I think we sometimes are like, I need to get this date, like I need to get this information, I need to like document it or whatever. But it sometimes can be a barrier because people may not want to talk about it or may not be comfortable with you yet, but allows people to understand why you're choosing to do it. I still also find many patients have never been tested in, for instance, extragenital sites for gonorrhea and chlamydia, which, so it may be new to them. And I also just would say, as far as the identity of the partners versus what they're doing with whom and how, I would say that also applies to PrEP, because if you look at PrEP guidelines, it's kind of like this bucket of people and this bucket of people. And I think that's limiting in the same way. And I think the discussions you have with people about PrEP and what it is, and if you may be a good person to consider PrEP, really is about what you're doing with whom, and are you using condoms or not? Have you had STIs before? And less relevant about their identities necessarily. So I think that part, because I do think the guidelines are not that inclusive or expansive in that way.
Yeah, I agree. I think that PrEP gets brought up a lot for certain patients with certain identities, and is not brought up for patients with risk factors often. I think or reasons that they might be coming in contact potentially with HIV is what I should say there. So I think thinking about what is your reason to suggest PrEP for certain patients. So, this is a multiple partner situation, but if they are the only partners and it's the three of them together for years and there's no new partners coming into the relationship, then you could think about, is PrEP indicated for them? And I always, PrEP is always a shared decision-making discussion with your patient, trying to talk about potential exposure to HIV and helping them figure out what's right for them. So I also want to make a plug for, folks who share needles and inject drugs. Also, you should think about PrEP for those patients. And I think it's not often something that we think about as an indication, or someone who's had multiple STIs, regardless of what they tell you about their sexual history. They're, clearly being exposed to different things. So that's a patient that you would consider talking about PrEP with as well. Any other questions about PrEP? I'm just saying PrEP is now standard of care, no prior auth. Excellent. Very, very good point. And then that if you limit your questions to partners, it's easy to miss instances of sexual assault. I think that's a really good point as well. So lots of different, situations and things to think about. And I think the more that you just kind of align yourself with your patient to have a discussion together about what types of testing we can do and how we can help you to stay safe, and allow them to kind of reflect on when they might be potentially exposed to HIV, et cetera, I think is the approach that I tend to take. Any thoughts about discussing condom use? I know this kind of came up early on with some of the comments. Do any groups have any discussion about that? You may not have gotten there in the time that you had.
Our group talked about counseling condoms for everybody, for every sex act, also with the acknowledgement that there are some people that you're not going to use condoms with, but just feel like it's really important that there are pills for everything, but syphilis is nasty. Getting a big old shot of penicillin hurts. There are, and also it can kill babies. There's lots of reasons to talk about condoms and why we encourage condoms, and to give the information and to not miss the fact that, we talk about the bucket. I don't know if we still use that term, the bucket of prevention strategies, but it really is an important one for lots of stuff. And for people with the uterus, not getting pregnant might be something to discuss too, even if we're just having fun and talking about, anal sex that accidentally turned into a front sex.
Mm-hmm. Yeah, absolutely. Really important point. And I think reminding people that PrEP doesn't, it's not 100% perfect, and it particularly doesn't prevent other STIs. It's really, I think, important to remember as well. So awesome. Yeah, condoms, I always encourage. We give them out a lot in clinic. I recommend having them available for patients to just grab if you can set that up in your clinical site. So any other thoughts or comments about this case? I know we have a few more to get to, but this is great discussion. I think thanks to everyone for being so engaged already. Any other thoughts, Dr. Trotter, that you want to add to this one?
There were two things quick things I wanted to mention is I really like the comment about breaking down, not using overly medicalized terminology. So, instead of saying oral sex, it's like when you use your mouth for this. Or I find, sometimes people will learn like, oh, are you an assertive or receptive partner? People don't, don't knowing like bottom, top, versatile, and those things. The other thing I would also say is that not only cisgender men have anal sex, so trying to get out of that kind of mindset, I think is also important. And the other thing was I don't think
you reminded me of another comment too, is if you're going to be talking about anatomy, it's helpful to ask people like what terms they use for different parts of their body too. So you're not like using a term that, especially for folks who maybe are non-binary or transgender, you don't want to be using terms that then actually are causing some sort of dysphoria for a patient. So just keep that in mind.
I thought of the final other thing was about condom use. I completely agree. And we need to be aware about the discussion that condom use is not for everybody. So I think that when I went through my medical education, I was taught that it's like condoms, and if you don't use them, you're like not responsible, and we should, there's a shaming component, honestly, and how I think we approach it. And I think it is important to understand that we should provide the information, give instruction, talk about it, but realize that condoms are not for everybody for various reasons, and you making them feel bad or like somehow shaming them in some way about that doesn't help. There are other tools like frequent testing, having easy access to testing, prep, and other things. So I do think that that's important when we have these conversations to really try. We have our own inherent biases sometimes, and to try to be aware of that when we have these discussions, because that helps you keep engaged and make sure that they have all the tools possible.
Could I just add that discussion of condom just shouldn't be yes or no, but that we know how to talk to people about when it works, when it doesn't, why, how to make it sexier, how to make it safer, how to make it more fun. And I just wanted 2 plugs. One thing that I always tell students is stop asking sexually active. It's the stupidest question ever. We are the only ones who say that. And that we please not assume that our heterosexual patients are monogamous either.
I love that. That's awesome. Yeah. So I see a great question in the chat from, do you go by Robert? I'm not sure. I don't know if you'd be willing to share. You mentioned the U equals U.
And then somebody said, what is that? So you can answer both.
My understanding of U equals U means a person who is taking antiretrovirals and their levels are undetectable, that they are also untransmittable as well.
Yeah, exactly. Sort of like a nice little acronym for it, I guess. Yeah, exactly. I think that's a really good, important point to make as well.
Hey, just about the U equals U, also to remind, I have a bunch of young clients who get they get undetectable once, and for the next 2 years, they tell people they don't need to use condoms because they're undetectable. And so it really, depending on the client, you need to do that education. Like it's supposed to be continued suppressed viral load. I think the official definition is for 6 months before you're considered to be officially untransmittable. Having said that, it's amazing. What a game changer. What a wonderful way to explore your sexuality. You have been living with HIV for 20 years and afraid you would kill anybody you touch, which, as we know, stigma kills people, and it can also make them massively unhappy. So yay, U equals U is great.
Yeah, absolutely. It's a great campaign. Awesome. We have one more slide about this case, which I realize we have next. I don't know if you want to bring it up. Go to the next one. This is just a quick, public service announcement. This is a great paper about how words matter and the phrases we use, talking about like high risk behavior, unsafe, those types of things can be very stigmatizing. And we wanted to also flag that there are diagnostic codes you can put in that are like high risk sexual behavior. Like that's something you can put in someone's chart, which is, as a patient, you can imagine that feels really terrible to read. And I've had patients actually who've changed a provider because they were on PrEP and it was linked to like high risk sexual behavior. This patient was like, why is that my diagnosis? Like, this feels really offensive to me. So when you're choosing your diagnosis codes, just keep that in mind, that like one, patients see them, and two, language matters in so many aspects of medicine, but this is the one we wanted to highlight. And I think so much of what we deem as risky or unsafe or high risk is very steeped in the stigma and sort of our assumptions of what is supposed, like what a relationship should look like and the ways that we are taught. So just kind of recognizing and trying to avoid those terms as much as possible. Any other comments on that one, Dr. Trotter?
No, I would just encourage everybody to, if you are not familiar with this article, to read it. It's great.
Yeah.
I handed out, I sent it to people because I think it really is kind of working on reimagining the way we use these terms or throw these terms out completely, some of them. And just for the PrEP part, there's a code for just contact or suspected contact to HIV. And there's also just a HIV, STI screening code. So those are the ones that I usually use. But yeah.
I think I found one that was like patient on PrEP or something. It's like the diagnosis. Yeah. That's a fantastic, I can't remember how they phrased it, but that was the one that I ended up choosing. It was like monitoring a patient on PrEP, which, is a lot better than the high risk sexual behavior, which is what had been previously linked for that patient. So yes, I'll look into which of those, and we can send them out for sure. All right, should we move into the next case? Any other last comments or thoughts about this first case? Big takeaways are pay attention to language, don't make assumptions, and ask questions in a way that, is inclusive to everybody's types of relationships.
Sorry to barge in. I have a very herpes question, like a very ID herpes question. If this is not the appropriate time for that, it can totally wait.
You can totally ask, that's fine.
So I work in the emergency department, and I have had multiple patients come in over the years saying, my partner tells me they have herpes, or I'm worried I have herpes. Like, what in the world do I do with this? And I have what I tell people, what I tell people I feel like is not very mainstream, at least as far as like what lay people would think or say or do. And so I'm curious how you guys educate people about herpes exposure, herpes diagnosis, and where you go from there.
Do you want to take this one, Dr. Trotter, as the infectious disease specialist on here?
Well, yeah, but I guess I would be interested to see what other people's ideas too, if they've run into this, because I do think that it is a very important topic that people really stress, like very much it's stressful for them if they have had herpes or their partner does, and understanding what that means for them. Does anybody else have thoughts about that? Or how you would go about discussing that?
We just have a request to repeat the question regarding herpes. It's basically how you counsel patients about herpes. Let's say they have a new diagnosis. What do you tell patients? And what guidance do you give them?
I guess since I brought it up, I'll say what I do and on the off chance that this is wrong, and I've been doing it wrong for years. Like if I'm telling them that my suspicion is that they have herpes, that I don't really have great confirmatory testing, I also try to say, like, a lot of people are exposed, a lot of people will test positive for antibodies. This isn't like, it feels bad. I'm not saying it doesn't feel bad to know this, but it is not life ending or sex ending. And that, yes, you are supposed to tell your partners, but also a lot of people respond irrationally and inappropriately to being told this. And so that is very nuanced advice. And most recently, someone was like, should I still use condoms or not? And so I had to explain like the limited utility of condoms for herpes infections as well and transmission. I think that's the highlights of what I try to hit on, at least in the emergency department.
I would just say that I usually try to get a sense of what they're concerned about. You know, is there concern about the complications of having it or how it's treated, or is it concerns about transmission to others? Because I think that people have different ideas, and I think we sometimes learn like a boxed answer, I guess. Like, this is my counseling about X. Which I think is like easy and good when you don't have a lot of time, but I think people themselves have sometimes different concerns. Like they may be really concerned about like, what does this mean about my health over a long time? Could I have complications? But I unfortunately, there is, we know that people can shed herpes even when they don't have outbreaks, and that can be a very big concerning thing for people. I encourage condom use all the time, but as you mentioned, it's one tool that doesn't make things 100%. And I think also sometimes a lot of my discussions are about negotiating their conversation with their partners. Like sometimes they just want assistance, and like, this is what I'm worried about with my partner. And I've actually had conversations with their them bring their partners to talk about it. It's with HIV sometimes, where they're just like, I want somebody to be there with me who can answer some of the technical questions and stuff like that. So I think all those things are helpful. And then I always talk about like suppressive versus episodic treatment, and that it is possible, if it's recurrent, that you can take medications all the time to suppress having outbreaks. And I totally agree with the antibody issue. Like antibody testing, I think, is very limited clinical use generally, because I think most people will be positive. And so most people are exposed to it. I have the same conversation about HPV. I'm like, we are all probably have been exposed to HPV. If you're sexually active, that's just something that's happened. So just because you're the one who has, a positive PCR from your cervical, like pap smear, or you have warts or whatever, I try to kind of destigmatize it, because it's true too.
Just wanted to highlight a couple of questions in the chat. So should we offer herpes testing to both partners, and based on the results, offer education or treatment? And then another comment: at the university clinic, we provide information regarding herpes and long-term effects. We discuss the need to disclose to your partner, and we offer couples counseling to assist with its discussion, and we encourage condom use. So a lot of similar things. And yeah, in terms of should we offer herpes testing, in terms of the antibody testing, I mean, you certainly could do it, but like we were just saying, people were probably going to test positive, and you don't know what that even means, because a lot of people have been exposed, so it doesn't really help you all that much. Is sort of my thought on that. Other questions or comments before we go on to our next case? Okay.
Sarah.
I'm gonna go to the next one. Oh.
I think in this discussion of herpes, I think the context matters a lot. For example, we have patients in which, one partner has a history of herpes, but they're married in a monogamous relationship, and it's very, very hard to encourage ongoing condom use in that circumstance. And the likelihood that the other partner is already a carrier of herpes is relatively high in that setting. So the discussion, changes on whether there's a person, if it's a person who is younger and has multiple partners, then the discussion is not any different from any other sexually transmitted disease and how to prevent it. Because herpes can happen asymptomatically doesn't mean that the way you prevent it is not the same as others. So the discussion there is, wear condoms and, try to protect yourself and your partners. But if it's if it is a committed monogamous relationship and they've been together for a while, then trying to say to that couple to use condoms all the time might be unrealistic. And it may be completely futile because the other partner is infected, regardless of what the blood test says. So context matters in this particular situation.
Yeah, thank you. I think those are really important points. And we do have a comment about remembering late third trimester HSV testing is important. Thank you for highlighting that. All right. Should we go into the next case?
Okay, so I can go through this case. This is actually based on one of my experiences. So this is a 57-year-old cisgender male who uses he, him pronouns. He comes to clinic for primary care management of his hypertension. So you kind of quote unquote inherited him, like he was somebody else's patient who left or graduated or whatever. And so he's new to you. So you kind of go through a complete history because you want to just kind of start with a new slate and get to know the patient. And so when you go through the social history or the past history, you ask, where do you live? And he says, I live in an apartment on the west side. Who you live with? And he says, my wife, we've been married for 15 years. Do you have children? No. So then you get to the sexual history. Are you sexually active? That term. Now I'll think more about the sexually active question. And he says yes. And you ask, what are the genders of your partners? And, he says women, and then he kind of hesitates. And then he says, and recently I've been sexually active with men or a man. So, and there's kind of a clear hesitation and then disclosure of that. So as far as this case, so when you're having this discussion and you think about kind of the responses the patient had to some of these questions, are there any pitfalls or assumptions that could have occurred in this conversation if you don't use open-ended questions? And how could that have changed the information you got, during the history and the conversation? The second one is, did you feel uncomfortable with the patient's response to the last question and why? And I would just urge you to be I guess, honest, because we'll talk about it, but be honest about that and have a conversation in your group about kind of your reaction to that type of response and that specific reaction that I described. And then how would you proceed with the conversation and the history? You're asking these patients, and the last one is to just be recognized. You ask these questions because the patient is new to you, but then how often should we be asking these questions? And should we only be doing it in that setting or not?
All right, any questions about this case? I put it all in the chat, so hopefully you'll be able to still see it when you go into rooms. Otherwise, I'm going to open the rooms for about 5 minutes or so again. You'll be in the same group, so some familiar faces. Any questions for clarity though before? Okay. Again, try to pick someone to be ready to report back for your group. Here we go. I have to reassign a few people, so you might end up in a room you weren't in before, so I apologize. It's not perfect science. Just reassigning people who maybe had to leave and come back. Okay, everyone should have been assigned to a room. If you did not get an assignment and you're trying to get into a room, let me know. Were folks able to see the case still in the chat in your breakout rooms? Still about 20 more seconds before all the rooms are fully closed. Some groups seem to still be discussing, which is great. Welcome back. Could everyone still see the case and the questions in the chat during the breakout room? Yes. Awesome. Okay. All right. Andrew, you want to put the slides back up so people can see? Awesome.
Okay, so I think everybody, yeah, everybody's back here. I wanted to see if any of the group representatives, I guess I would say, or anybody in any of the groups wanted to start with just a discussion in general about your discussion or addressing any of these specific questions or things that maybe you talked about that you wanted to bring to a larger discussion. So anybody feel free, or you can put things in the chat.
Hi, this is Min. I'll jump in with the first question. I think we said immediately if you just assume that he's married and he's in a monogamous relationship, you would have never received that answer about possibly multiple other partners and or that he had a sexual interaction with the man. So just asking the question I thought was important, and then asking specifically, what are the genders of your sexual partners? If you had not asked it in that specific way, again, he may not have felt like it was that environment for him to open up to say that he was also recently with a man. So I think he may never have gotten that answer unless you asked it in this specific way and assumed that he was maybe just having sex with women because he was married already.
Yeah, great. I think that's a great point. I think that if you're somebody who's integrating this kind of open-ended questions more and more in your own practice, maybe you didn't initially do it, or that's something you're working on. What I always like to tell people is, like, when you answer the question, they answer something and you're surprised, that means you already had an assumption about what it would have been. And so I think a lot of it is being cognizant of that and just recognizing that. And it just happens, but having these open questions and open language allows you that space and allows them to feel like there's a comfortable environment to share that, which I think is really changes, I think, sometimes what the information you're getting and also your relationship with your patients. Any other people from different groups want to talk about any of these points? Maybe about how you reacted to the situation and kind of what you would do next.
We talked about a couple of things, but two things that came out. The idea that, like, okay, this person said also was sexually active with a man, but then the question of, well, what does that mean about what body parts were involved? Because that might differ from an assumption regarding how that person is identifying the gender of their partner, and following up on that. And then the other thing they talked about was the idea of asking these questions of everyone routinely, whether they're new or not, and how the answers may change based on their actual situation or their level of comfort proffering real information about their lifestyle.
Yeah, I think that those are great points. And I would just say, that sex is still a sensitive subject for many people and many communities, many patients. And so, you know, sometimes there are situations where it takes time for people to tell you, to share things with you. That's not necessarily, I mean, we always can work on how we're approaching the language we use, but sometimes it's just trying to get over that stigma. And it's very, very real. I think being aware of that and realizing it may not be something that I mean, again, we can all be working on our language all the time and we may make mistakes sometimes, but sometimes it has nothing to do with how we're asking questions. It just takes time for people to build the rapport and trust. And people have their internalized stigma sometimes about those things that affects their comfort level in sharing. How about, how would you proceed? Like, what would you do next? Or anybody have thoughts about that or ideas about that?
Our group was kind of discussing first, like thanking the patient for sharing the information and trying to like coalition build with them. And then like we were talking about getting further histories about like, you know, the specific sexual encounters, as well as trying to determine if patient has discussed with his wife about the activity, because that can like change her risk as well, and kind of like proceeding in that fashion.
I think similarly, kind of, you know, I've mentioned, you know, if you ask about his wife, though, you know, especially, I think Dr. Trotter brought this up in our group, that kind of if she's receiving care at the clinic, that it's not that like we're not going to share that information with her. That what we talk about, you know, stays between the two of us, kind of. Also, kind of at least moving forward. I know, you know, it says he's 57 and he's been married to his wife for a while, but maybe saying, you know, you don't have kids, you know, are you still using birth control? Might be, or, you know, are you using condoms? You know, kind of, you know, presenting multiple different options for contraceptive and just sort of, you know, safer sex accoutrements. I don't know what the right word is for it, but, you know, kind of just presenting that as like as a, you know, way to show that you're not passing any sort of judgment or, you know, yeah.
And that's all cued around the idea that is the assumption that they're sexually active with the wife.
Yeah, our group discussed that a little bit too. You know, sometimes we make assumptions that the relationship with the wife is sexual or is monogamous, or so maybe just asking some open-ended questions about their relationship with their wife and or others might be a place to take the conversation.
Any other thoughts from other groups?
I guess I would just say to be careful. It feels to me like suddenly talking about the wife, it is stigmatizing. And not that we should never talk about the wife, but he's just shared something he's very likely not shared before. And remembering that he's the patient in the room at the moment, to let him get to that. My favorite question is, tell me more. So, and go from there.
Yeah, that's a great point. And there was a message in the chat to remember that the wife might already know and may be aware and be okay with it. We make we're kind of making assumptions about that aspect. So one of the reasons I really wanted to have this case is that I think the level of what you do next is a fun, not fun, but interesting kind of thought discussion, because I think in some respects, what I'm hearing is people want to ask more questions to be able to get to counseling points or information we can provide to them about, you know, different preventative, like health aspects, condom use, testing, even concern about your own concern about the wife and the potential exposure to, you know, STIs or whatever. But realizing that, you know, he's your patient in front of you. And although that is all important, I think you do have to be very careful. And what I think that you just have to have him guide you as far as how much, we can barrage him with all these questions about all sorts of details of everything. But I think it's really trying to understand from his perspective how much he wants to talk about it right now. Because it's just complicated, I think. And I think that's one of the interesting aspects of this. I would just suggest trying to let him lead you to, tell me more, or, tell me about that, or, and see if he kind of goes a certain direction with a conversation and kind of following him through that. Yeah, and that, yes. And another thing in the chat was, that was mentioned is that, if he does say that he's having sex with a wife and he himself tests HIV positive, we're not obligated to tell her, or with any other STIs. And that's correct. It's reportable to the health department and they may do tracing, but we ourselves don't have to do that. The other thing I really like that somebody brought up is the underlying reinforcing confidentiality. I personally feel that doing that no matter what is important, because it can just be a safety net. Sometimes when you just say that, it's obvious to us, but it's not always obvious to our patients. And one other comment was, if the clinician feels a bit perturbed by this revelation, will it be a good practice to move on to the next question and come back to this one? Yeah, I mean, I think it depends on, I guess sometimes you have strong reactions to things, and that's something that can occur in different situations. I think that you have that option to do that. I personally would just suggest that though you clearly acknowledge what he said and reinforce that, if you can, reinforce that that it might have been challenging to disclose that to me or share that with me, but you're kind of glad that you were able to feel comfortable talking about it. Because I think if you skip it, like you don't acknowledge it at all, it reinforces that either you don't want to talk about it or it reinforces stigma. And I think even though you may have a reaction, I think after you think about it and stuff and get your kind of maybe talk to a colleague or kind of gather a game plan, you may, be able to readdress it in the future.
This is Martin about family medicine. I feel like that would be like a missed opportunity, because I mean, the patient is talking to like a near total stranger, right? I mean, he's seeing me for the first time and he hesitated, but he broached it. I would feel like I kind of honored that he mentioned it to me, first of all, that he felt the safe enough to broach that. And the fact that he broached it to, again, pretty much a stranger means that I think for him, that's a big deal. And I really wouldn't want to miss that opportunity to address a bit more about what's on his mind about that. And even if you acknowledge that and say that, let's talk about it at another time or something like that, I really feel like when the patient brings it up is the best time to actually address it.
Yeah, I think that's a great point. I do think that there's an opportunity there as well. Any other thoughts from anybody else? Any other viewpoints or questions about this? So one of the other comments was based on that revelation, should we offer screening, provide condom education, ask about PrEP? Yeah, so I think that this is, I mean, yes, potentially. I mean, those parts of the discussion are there. I just think that I think we should be ready to provide that information. But again, my own approach would be to try to allow the person to guide those steps, because it may be overwhelming. He may feel like just saying that was like enough, that's it. And he just doesn't want to talk about it anymore. And I think just trying to have some open-ended questions to get a sense of that and see where he goes and then following him through that conversation is helpful. Certainly all those things should be discussed eventually. But I think understanding that just letting him guide you through it, I think is important. Yes, and then another comment, being sex friendly goes a long way. Yeah, I think, and also just being very neutral and just open is helpful, and it allows us to be more patient centered. I would say, because you're kind of allowing them to give you, a cue as to where to go with the discussion.
I just want to add, I like this discussion because I think it's such a good reminder that sexuality, gender identity can be so fluid and change with time. And maybe this is the first time that he's talked to anybody about this. And that's such a big thing that he felt comfortable to do that. And I really liked the points that were made about really just making space, because this could be a really, big part of his identity that he's trying to figure out. And being able to be there and listen and provide some guidance is really huge. So I talk a lot about making sure to continue to ask these questions as you continue to see a patient you maybe have known for a long time. I bring this up a lot when talking to pediatrics providers, because especially adolescents, folks are figuring things out. But as you're older, like any age, people can come out at any age, or like find new aspects to their identity or in their sexuality at any age. And I think this is a really good example of that.
The only other thing I would mention is that my experience in this situation was that having this conversation has incredibly built the rapport I have with this person, because having this discussion and then having that, and he actually told me that I've never told anybody this. I probably will never tell anybody else this, but he felt comfortable being that honest. We have to realize that although in some of these situations, initially, we may feel uncomfortable or not sure about how to proceed, it can be a really important milestone in your longitudinal care of the person. And it's really an awesome aspect of what we do every day as clinicians, that we are able to be in that position and walk with a person through, these kinds of issues that may have bothered them or been challenging for them for a long time. And then there was one other comment, but should we consider the wife's safety because we're here to provide care for the patient and his family, right? Or is it not so in this case? And then another comment, we're providing care for the patient care first and foremost, or providing maybe the patient. Yeah. Yeah, I think so. I mean, from my perspective, I think the concerns about the wife's safety and risk for things or protection and testing is coming from a good place. But I think I would say that we still have to focus on the patient that's in front of us. And then see how, because maybe he also has that, for all we know, he could want to talk about that. So what can I do? Or as was mentioned, maybe the wife already knows and is okay with it. You just don't know. So I think those considerations are important, but that we do need to kind of have continued conversations about it over time.
I think we may have, if we get to we can probably do a short discussion for the next case. I know we're only have about 10 minutes left. What do you think? Should we dive into the last one quickly, or do you want to have some more discussion for just questions?
Because we could also just open up to general questions if people.
This has been awesome. Everyone's been really thoughtful in sharing their thoughts. This has been really, really great. Would folks want to see the next case quickly to have a little bit more discussion, or are there big burning questions folks have for the larger group?
We could also do the last case just together, I guess.
Yeah, why don't we do that? That's a great idea. We could do that.
So.
Yeah, we actually had, I think, 5 cases total, just in case people were not feeling very chatty. So this has been wonderful to be able to spend more time having a robust discussion about each one. So this is great. Do you want to read this one?
Yeah, sure. So this is the third case. So 24-year-old. So I usually approach this as like, this is what it says in Epic because, or in your EMR, because that's like literally what you see before you see the patient. It's like the real world thing. But anyway, so this person's on your schedule, 24-year-old trans woman, uses she, her pronouns, comes to your clinic. So in your schedule, it says that she's there for evaluation of like environmental allergies or something like that. And then when you meet her, she kind of discusses the allergy symptoms for like 2 minutes or like a short period of time. And then kind of discusses to you that, oh, I'm interested in learning about hormone therapy, or I've heard about this and I want to, talk about that. And the reason the question, I think questions around this case are really about like, some people will come to you seeking gender affirming care or hormone therapy or other parts of gender affirming care. But other people, it's just kind of a component in addition to other care that they're seeking. How would you proceed with this conversation initially when somebody says, I saw on the website that you provide this, or I'm interested in this. And then how would you approach it if you yourself don't feel comfortable providing hormone therapy or having deciding on the medications itself? What would you do? And that second question has come from a lot of questions that have been given to me too, especially within our system and in different levels of trainees. So the first, does anybody have any kind of comments or questions? And the other thing is, I would say, I brought this case up is I've had this experience multiple times where in the system, it says all this stuff. And then I see and meet the individual and it's like, yes, it's that, but it's actually a lot of other stuff. There's a lot of other things. And I think it's because people are not always comfortable, or there's an unknown about meeting a provider or going through the system. And then once they meet you, then these other issues come up. Thoughts about how you would proceed about this conversation, proceed with the conversation. What do you do next?
I think at least, sorry.
I just wanted to highlight in the chat the comment that sometimes it feels safer to put a different reason. So go ahead.
I think at least how you would proceed is maybe just sort of identifying. You mentioned your allergies and also hormone therapy. Which do you want to talk about first? Putting it back on them to direct the discussion might be helpful.
Anyone else have any thoughts?
Hi, this is Min. Yeah, the only thing I can think about the second question is to then not say, well, I don't do it, but know resources that you can provide the patient, right? Maybe have that in your back pocket of specific things that maybe you don't feel comfortable doing because you're not trained enough, or it's just not your area. For example, an allergist may not feel comfortable, if it is an allergist, to provide hormone therapy, but to say, oh, we have this clinic, or, this is something that I would recommend you talk to your primary care doctor, or, have something in your pocket to say, this is the next step that I think may help you to answer that question if you yourself can't.
Yeah, I mean, I think that's a great point, Min, especially in the setting of being in a tertiary center. So many of us are subspecialists, and so I think knowing, for instance, at your institution, who are providers that are in primary care fields that provide gender affirming hormone therapy or gender affirming care in general, I think is helpful. On our website in the health system, we have a section where it's LGBTQ inclusive care, but then in the profiles it will say gender affirming care as well. That can be helpful. I would just say, in my perfect world, is that all of this would be integrated in primary care no matter what. And so I understand that some people in primary care fields their reaction to this may be that I don't know how to do this, I don't feel comfortable doing it, and that's fine. But I would suggest that you do encourage people to find ways to learn about this and integrate it, so that, because what I found, I provide this in the setting of HIV primary care, and integrating everything into one place is easier for individuals, and it just makes sense. And I think it supports their engagement and care. And it also, I think, allows the person to feel that you see them as a whole person. You're acknowledging and affirming them in those ways. And so I think that trying to get this integrated more in primary care training and practice is an important step too.
I know we only have a couple minutes left, but I definitely want to say that I 100% think that primary care providers should be able to provide hormone therapy. We know that it's really hard for folks to access care in a lot of parts of the country, and so this can really expand access for folks. And there's some different resources going in the chat. I put in the UCSF guidelines, which are great as a provider to look at for starting feminizing or masculinizing hormones for folks. Fenway is also fantastic. I was with my one arm trying to get that link, so thank you for putting that in the chat. Those are some great, and the ICW path was also put in there. So there's several different fantastic guidelines that you can reference, and also always feel free to reach out to us if you do have a patient and you're not sure where to send them or how to start the process. Many patients already are taking hormones, or maybe got them from a friend, or have already been prescribed them elsewhere. And so having that open conversation at the beginning about what their experience has already been is really important.
One thing I would mention about the trainings is that through the intranet tile, there's like instructions on how to access both the National LGBTQ Health Education Center and the HEI resources. And the reason it's helpful is that we register as an institution. They register you as someone from our institution, and there's tracking. And so that builds information about how our staff is accessing the education and how much we're utilizing it, which I think is an important aspect as an institution of, that our staff are pursuing those things and doing it. And I know that there's also continuing ed credits for various disciplines that are available. So I would just mention that as well. And then there was a mention in the chat about it's important to ask if they're buying them, I'm assuming gender affirming hormone therapy, and if they have clean needles, if they're injecting someone else. Yeah, one thing I would also mention is it's not uncommon for individuals to get hormone therapy on the street. And so I think that's also an area to have discussions that I've had discussions with my own patients about, because obviously you don't know exactly what that is, and there's different aspects of that, and you providing it in a monitored setting where you know what is being given is important, I think, as well. But that is a very common issue.
Thank you so much, Drs. Mesmer and Trotter. I just want to, at the end of the hour, just thank you on behalf of the DOM Inclusion Council and the Internal Medicine Residency Program. One thing, I've been in medicine for 20 years, and these topics are new to me. I will be the first to admit it. The couple sessions that we've had, what really hurts me deeply is that we can turn individuals away from healthcare so quickly with such negative interactions. So these discussions are so important. And I personally think we can't talk or learn enough about LGBTQIA plus inclusive care. And since you have 2 or 3 more cases, maybe we could have another series on this in another 2 or 3 months. So if you could maybe have a final statement for us before we let everyone go.
Go ahead, Sarah, if you want.
Yeah, I would just say that thank you to everyone for being here and participating. It was really fantastic discussion. And I know I'll speak for myself. I'm happy to chat with anyone anytime about any of these questions that come up. If you have a patient, I do prescribe hormones, so I'm happy to talk through that with anybody if you have questions. And Yeah, just thank you to everyone. Anything you want to add, Andrew?
No, just thank you everybody for your time and engagement in the discussion. And, hopefully maybe we can continue this discussion again in future programming. I think it's really important to talk about this in a very real world case-based situation, because you run into it in many different ways. And I really appreciate everybody's time and effort in being involved and interactive, even across this virtual. I envision a day where we could actually be and seeing each other in person and doing it. So thank you, everybody. And I think there were maybe a few questions in the chat about resources. So we may just be able to throw them to get some of that information together and then send it out to all the participants.
All right, wonderful. Thank you, everyone.